From the American Neurological Association, I'm Adeline Goss. This is ANA Investigates. Lysosomal storage diseases are progressive, inherited disorders of metabolism, many with devastating effects on the nervous system. Some of these diseases, like infantile-onset Pompe disease, can be treated to some degree in childhood by giving back the missing enzyme, a strategy called enzyme replacement therapy, or ERT. But a recent study reported in the New England Journal of Medicine goes a step farther by giving enzyme replacement therapy to a fetus with Pompe disease for the first time in an attempt to treat the disease before it does any serious damage. The paper's first author and my guest on today's show is Dr. Jennifer Cohen, a pediatric medical genetics physician scientist at Duke University Health System. She'll walk us through the potential benefits of in-utero enzyme replacement therapy and other cutting-edge approaches to treating genetic neurologic conditions, a relatively new field called fetal therapy. Welcome, Dr. Cohen. Thanks so much for joining us today on ANA Investigates.
Thank you so much for having me, Dr. Goss. I'm very excited to speak with you all today about this topic.
So, let's start with a little bit of background. Pompe disease is a lysosomal storage disorder. And if I remember, it's a deficiency in acid maltase that leads to accumulation of glycogen and leads to tissue destruction. And the disease is now often diagnosed by newborn screening. Babies are often started on enzyme replacement therapy with a drug called L-glucosidase alpha. Currently, what is the prognosis when newborns are diagnosed and treated with L-glucosidase alpha?
Absolutely. So infantile-onset Pompe disease and Pompe disease in general is actually both a lysosomal storage disease as well as a glycogen storage disease. So it's an interesting condition in that regard because it falls into both of those storage categories. So it can also be known as glycogen storage disease type 2. So in the literature, you'll see combination of different names actually referring to Pompe disease. For infantile-onset Pompe disease in particular, it is a more severe condition, earlier onset, and also more progressive than the later onset form. And this is because of a deficiency, as you mentioned, in the enzyme. And when you treat with the enzyme, the prognosis is life-saving, essentially. Without any enzyme replacement therapy, these children were passing away by the age of 1 to 2 years. And this is due to cardiorespiratory failure as well as the skeletal muscle decompensation. With treatment, though, we know that ERT has been life-saving for the population of infantile-onset Pompe disease children. And while it's a huge improvement in the prognosis, it's still imperfect. And what we aimed to do with the fetal therapy trial is to intervene before muscle damage occurs, skeletal muscle, cardiac muscle damage, and essentially improve the prognosis and outcome for these children.
You're pointing out that some of that damage begins to accrue in utero, and so even treating right after birth may not be soon enough. And your group published this case in the New England Journal where you treated Pompe disease with in-utero enzyme replacement therapy. Can you just walk me through how this procedure is done in general terms?
Absolutely. So the fetal therapy that we used for in-utero enzyme replacement therapy marries two different therapies. First, the FDA-approved enzyme replacement therapy that we would normally give to a child postnatally, and it administers this therapy using the umbilical vein injection procedure that's commonly used for umbilical vein transfusions, blood transfusions, when fetal transfusions are needed. So it's a procedure that is safely being done for children who need fetal blood transfusions. And now we're repurposing that procedure in a sense to instead inject through the umbilical vein the enzyme that we would use for enzyme replacement therapy postnatally, the same exact medication.
Am I correct in saying this is the first time this has been done in a fetus?
It's the first time it was done in a fetus with a lysosomal storage disease. There had been a trial with protein replacement therapy in ectodermal dysplasia, hypohidrotic ectodermal dysplasia, but not the exact same procedure and certainly a very different type of disease. Our procedure actually was repeated injections. So for the patient that we published in the New England Journal of Medicine, that patient received 6 infusions total every 2 weeks from 24 plus 5 weeks gestation through about 34 weeks gestation. So that was also different than previous fetal therapy that I mentioned with ectodermal dysplasia.
And so this patient that you treated wound up with normal clinical outcomes at 13 months compared to two siblings with Pompe disease who had not undergone fetal therapy and who had had progressive motor deficits starting shortly after birth and who passed away from the disease before age 3. Why do we think that in utero treatment is more effective than starting enzyme replacement therapy as an infant?
So we know that with infantile Pompe disease, we can see cardiac muscle damage occurring in utero, as you alluded to in an earlier question. And we saw with these siblings, we had the opportunity essentially to understand the siblings' medical history, and that really helped us interpret the results from this first patient treated in utero. So the very first sibling in the family, who was essentially the first patient in this family diagnosed with infantile Pompe disease, was actually diagnosed clinically, which can often happen without newborn screening. These patients are diagnosed typically between 3-6 months of age. And this patient was diagnosed around 5 months of age, that initial proband or the initial patient for this family. So she received the appropriate treatment for her disease, which was CRIM negative, and CRIM stands for cross-reactive immunologic material. So CRIM negative infantile Pompe disease is actually the most severe form of infantile Pompe disease. And that severe form basically means that little to no endogenous enzyme is being made. And these patients are at the highest risk to mount an antibody response to the recombinant enzyme replacement therapy. So that very initial patient in the family received the appropriate care, which in this case is immune tolerance induction regimen, which was developed at Duke, actually, this protocol to give rituximab, methotrexate, and IVIG before the first dose of enzyme replacement therapy. So that first child got all of that appropriate treatment, but unfortunately, because she was diagnosed somewhat late and the severe disease, she succumbed to her disease and did pass away by 29 months of age due to cardiorespiratory severe symptoms. The second child to be born in this family with infantile Pompe disease, again, CRIM negative, was diagnosed prenatally. So she was not treated prenatally, but they were aware of the disease in that second sibling prenatally and were able to do fetal echocardiogram. And what we saw was that by 34 weeks gestation, this patient already had severe hypertrophy of her heart. And so we were able to compare the fetal echocardiogram of that sibling, the prenatally diagnosed sibling, to our prenatally diagnosed and now prenatally treated patient. Our patient had no cardiac hypertrophy prenatally, having received multiple infusions at that point, and remains completely normal left ventricular mass index throughout her entire life. So that was a really big difference between the patient that we treated in utero and, of course, the clinically diagnosed sibling. Of note, the prenatally diagnosed sibling did not receive any treatment postnatally due to a choice by the family to pursue palliative care. Motor outcomes, though, we are able to compare. We were able to see that there was head lag and motor deficits seen very early on in that patient that was diagnosed prenatally and therefore followed very closely in early life, as well as, of course, the clinically diagnosed sibling that was treated but had severe motor deficits. And we see that in comparison to the patient treated in utero. She had completely normal motor outcomes. She walked independently at 11 and a half months of age, and the creatine kinase levels have been completely normal, which is a marker of muscle outcome, essentially. And that's something we don't typically see in infantile patients. We usually see elevated creatine kinase before they're first treated, and we were seeing completely normal creatine kinase levels early on, after birth, and throughout her life.
So you've hinted at a couple reasons, I think, why this intervention was effective, but just to dig into those a little bit more, it sounds like one of the issues in Pompe disease, and in particular patients who are CRIM negative, which again means cross-reactive immunologic material negative, these patients have a poorer response to enzyme replacement therapy and a worse prognosis. And there's this problem where when the patient receives enzyme replacement therapy, they mount an immunologic response to that therapy, which then makes it more difficult to treat them. And it sounds like one of the opportunities with in-utero enzyme replacement therapy is that the fetus's immune system is less likely to reject a biologic therapy. Am I getting that right?
Yes, that's correct. The one thing I'll say, though, is that immune tolerance induction, when appropriately administered, does solve that problem for many patients. So many patients do not mount an antibody response when they are appropriately treated with that immune tolerance induction. But like many things in medicine, it is imperfect. And there are patients that sort of break through that immune tolerance induction if they have severe CREB-negative mutations, for instance, and can still mount a response. And an example of that was actually our patient's first sibling, who, as I mentioned, did receive appropriate immune tolerance induction before her first enzyme replacement therapy. She actually mounted an antibody response and had to be retreated with an entire round of immune tolerance induction again around 17 months of age for her. When we compare that to our patient who was treated in utero, she actually received enzyme replacement therapy with no immune tolerance induction because we didn't give the immune tolerance induction medicines in utero. We were hopeful that there would be some tolerance induced just based on, like you said, the immature immunology of a fetus and the special environment of the fetal-maternal immunologic interactions. And what we saw was that after 5 infusions, she did mount a very low antibody response, but unlike her sister, her antibodies came down very quickly with our typical immune tolerance induction regimen. That methotrexate, rituximab, and IVIG basically brought all of those antibodies down, and she's had no antibodies of late. And so that's really a really good thing in terms of continued efficacy of the enzyme replacement therapy.
And how old is the patient now?
The patient just turned 2 years old a few days ago.
Wonderful. So, let's talk about the big picture here. This opens up the possibility of treating diseases almost before they start and avoiding waiting, until after birth and potentially missing a window of opportunity to prevent more irreversible disease. What other types of neurologic conditions might be amenable to in utero enzyme replacement therapy?
Absolutely. I think that's a great question and certainly something we've been thinking about with this trial. And in this trial itself, it's a trial for 8 different lysosomal storage diseases. And some of those storage diseases are actually even more neurologically impacted than Pompe disease. We're also treating MPS 1, MPS 2, MPS 4A, MPS 6, and MPS 7.
And by MPS, you mean mucopolysaccharidosis, is that right?
Yes, thank you. Mucopolysaccharidosis. And then we're also enrolling for Gaucher disease type 2 and 3, which are the neuronopathic forms of Gaucher disease, as well as Wolman disease. One of the main drawbacks to enzyme replacement therapy for diseases that have any sort of CNS involvement is that the enzyme does not cross the blood-brain barrier. It's systemically administered and it does not have a way to get to the brain. So while it might help the systemic symptoms, the bone symptoms, the muscle symptoms, the liver symptoms, it won't cross the blood-brain barrier. Our hope is with this trial is that because the blood-brain barrier is essentially open in a fetus, that enzyme replacement therapy that we're systemically administering, we're going through the umbilical vein instead of a peripheral vein, it can just freely cross the blood-brain barrier. So Pompe disease, infantile Pompe disease, actually does have some white matter involvement. The hope is, again, that, it was crossing the blood-brain barrier while she was in utero. We don't think it's continuing to cross the blood-brain barrier postnatally, but perhaps that might be enough for infantile Pompe disease, where the white matter disease is not a significant portion of the disease. It is a portion of the disease. What we think about the other mucopolysaccharidoses, the MPS disorders I've been mentioning, there we know it will be important to kind of bridge them to some sort of treatment, either hematopoietic stem cell transplant, or whether it be a clinical trial for a gene therapy or a clinical trial for a blood-brain barrier crossing enzyme replacement therapy. And so I think the hope is that the in utero enzyme replacement therapy can keep the patient healthy enough, bridge them to something that might be more penetrative postnatally to the CNS.
Can you talk a little bit about where we are with gene therapy for fetuses with known neurologic diseases?
So I think for gene therapy in the fetal realm, it's still in animal models at this point. We are definitely gene therapy in humans in the postnatal realm. There's basically two main categories I like to think about gene therapy: direct gene transfer versus indirect gene transfer. The direct gene transfer mainly focuses on vectors and such as adeno-associated viral vectors, for instance, that basically give the working gene back to the patient through some sort of vector, systemically administered or sometimes administered intracisternally if it's a CNS, primary CNS disease. And then we have the indirect gene transfer, which mainly focuses on using autologous stem cell transplant from the patient, sort of re-engineering those cells to have the working gene and then giving those stem cells back to the patient. And so I think gene therapy in the fetal realm, it is a little bit more complex, especially because of the immunologic considerations that we deal with. We often give immunosuppression regimens because there can be mounted immune responses. How do we manage that with the fetus? As well as with direct gene transfer, the cells are dividing still. And so we don't yet even know in an adult if we'll need to redose, for instance, gene therapy, let alone in a fetus whose cells are still dividing, what that redosing looks like, especially if once you've dosed with gene therapy, such as an adeno-associated virus, it sometimes is hard to go back in and redose with even a different adeno-associated virus that might have overlapping antibody response, and the body might recognize that as a problem. So I think there's a lot more still to be sorted out in the field. I'm hopeful that we will get there, of course, but I do think going after FDA-approved treatments and administering them in utero might be the way to go for now until we have the postnatal gene therapy kinks worked out, so to speak.
Thank you. Thank you for summarizing that. That was a very concise, clear summary of a very complex and expanding field. Just one other question about this trial and about your experience discussing this type of intervention, gestation. So, a gestational age where preterm birth would be a big problem. In your experience counseling families about in utero enzyme replacement therapy, how do they weigh this risk against the risk of waiting to treat until the newborn phase and potentially accruing more pathology?
My experience has been that the patients that we've enrolled in the trial so far have a family history of the disease. And so they've seen the devastation of the disease firsthand, as well as the imperfections in our postnatal treatment. And I know in the case of this first family that was treated with infantile Pompe disease, I think they were eager to do something more aggressive this time and to really see what was new. They have been very happy with the outcomes of this child and feel very blessed that she is as healthy as she is. So I think we're all very cautiously optimistic. She did just turn 2 years old, so we're continuing to watch her very closely, especially the antibodies and her progress with motor skills. And so I think we're all cautiously optimistic. But I think the result so far has been a positive one, and this family has been very happy with those outcomes. And hopefully, if we continue with these trials and prove, safety in the long term, that can be a true opportunity for many more families to come.
Great. Yeah, I hope so. One other question about counseling families. Big picture, as we look forward and hopefully develop more and more fetal therapies, how might this sort of expanding array of treatment options affect parents' decisions about prenatal carrier screening and prenatal genetic diagnosis? Do you have a hint of this yet?
Yes, I actually really appreciate this question because this is my passion in terms of my research, is to actually make prenatal carrier screening and prenatal testing more expansive and more available to patients. So I do think that historically, a lot of patients may not be getting prenatal testing, diagnostic testing for some of these conditions because they feel that there's nothing that they would change and there's nothing that they could do differently. And so my hope is that if there are treatment options available, that might change patients as well as providers' outlook on who should be getting prenatal diagnostic testing. That covers the patient, of course, that has a family history, right? They have a family history of the disease. All of the conditions we're talking about are either autosomal recessive or X-linked today. And so those are all inherited conditions. There's, of course, a host of de novo, non-inherited genetic conditions, which we are not discussing really today. But for those, the inherited conditions, if we have a family history of it, that clues a family in to say, maybe I want to test this current pregnancy for that same condition, knowing that I have either a 25% chance risk for the autosomal recessive or up to a 50% chance risk for a male fetus in an X-linked condition. The other side of this, though, is prenatal carrier screening, which you mentioned, and I'm really glad you did, because ACMG, which is the American College of Medical Genetics, put out in the last couple of years a recommended tier 3 screening list of genes that they recommend that should be universal screened. And so this is saying that expectant parents, couples should actually receive universal screening for a number of inherited conditions. And I think that will also change. I think those recommendations will also change with the changing landscape of fetal therapy opportunities. Because in this case, the prenatal carrier screening, you don't need to have a family history to clue you in. You can take a brand new couple expecting their first child or looking to conceive their first child, ideally you're doing prenatal carrier screening before conception to give time for decision making and appropriate testing. And that would allow a couple to know we have a 25% chance risk, a 50% chance risk of these conditions. And now let's see, what are the opportunities? What are the options for potential treatment prenatally or even immediate postnatal? And I think that's the key here, is that this does not mean that every patient needs to be treated prenatally. But if you know that you are at risk for infantile Pompe disease and you can maybe test the fetus prenatally, but not intervene. Let's say they don't want to take the risk of in-utero enzyme replacement therapy. We can start treating that patient on day 1 of life. And we know from our research at Duke, as well as outside institutions that are also publishing similar research, we know that treating on day of life 1 is actually much improved over treating by 3 or 4 weeks of life. And so getting more opportunity and expanding the access for patients to have insurance coverage for this testing, to be offered this testing and counseled on this testing, I think is going to be really key in changing the whole field of genetic treatment.
Well, thank you so much, Dr. Cohen, for joining us on ANA Investigates to talk about this real frontier in neurology of fetal therapy.
Thank you so much, Dr. Goss. Thanks for having me. It was a pleasure.
That was Dr. Jennifer Cohen, pediatric medical genetics physician scientist at Duke. ANA Investigates is the official podcast of the American Neurological Association. The show's producers are members of the ANA Education Innovation Committee, chaired by Megan Ritchie. I'm Adeline Goss, podcast host and executive producer. Our program was produced today by Caitlin White and me, with help from Jen Hurley, Masoom Desai, Michelle Johansson, and Megan Ritchie. You can listen to past episodes of the show and access all of the ANA's educational programs at myana.org. That's it for ANA Investigates. See you next month.